director for the ARC Training Center for Medical Implant Technologies. So the center has been running seminars or webinars and on technology from industry perspective and also from clinician perspective. So today we are really happy to have two well-established oral maxillofacial surgeons, Professor David Wiesenfeld and Mr. Ricky Kumar, to give some idea about a patient-specific prosthesis in oral maxillofacial surgery. So I know some of you in the audience have been working on patient-specific implants and patient-specific algorithms. So you will really benefit from today's talk because we are hearing from the user perspective. So you have, I'm sure all of you have read the bio of David and Ricky, and I'm sure you are equally impressed, with what we have, the expertise, the years of experience that they have in this field. So without much further ado, I'm going to pass the time to David and Ricky, and we will hear from you now then. Thanks.
Thank you very much, Peter, and thank you for the opportunity to present to such an august group.
David, sorry, just to interrupt you, we are not seeing your slide. Yeah, we're seeing your screen, your computer screen, but not slides. Yes, all good. Thanks.
Go back to the beginning. Thank you very much, Peter, for the opportunity to speak to such an august group. Thank you to Ricky for backing me up and giving balance to my presentation. So Peter has given me an introduction. For those of you that don't know me, I mainly work at the Royal Melbourne Hospital clinically. And I'm going to speak to you about maxillary and mandibular reconstruction after cancer treatment. I want to acknowledge a few people because everything we do is teamwork. It's not an individual. Anand Ramakrishnan, who's the head of plastic and reconstructive surgery at the Royal Melbourne Hospital. Richard Barton is a plastic surgeon within the department. And Professor Ian Taylor is the former head of plastic surgery. And Ian was a strong supporter for the evolution of fixation and the development of free flap transfer techniques at the Royal Melbourne and for the world. The engineers at Leica Smith, Stryker and KLS, whom we work with, and the maxillofacial surgeons at the Royal Melbourne for their support and contribution to patient care. So why do we actually bother with doing VSPs and patient-specific implants? The benefits are the efficiency and speed of treatment. It saves operating time of about 2 hours to be able to have everything prepared and all of the prostheses custom made, rather than having to try and fashion bone segments to out of the box prostheses. The cost saving at the Royal Melbourne, the theatre is about $1,655 per hour. And that was in 2017. And that didn't make any allowance for the second surgical and the nursing team. In the Victorian, these figures are out of the Victorian Auditor General's report from 2017. I think the figure is closer to $3,500 per hour today. Having the extra staff for running two teams. So we have a team for resection, that is cutting out the cancer, and we have a team for reconstruction, and there's a balance between the two and linkage between the two. It's a lot better if the two teams can operate simultaneously rather than one starts and finishes, and then the other starts and finishes. So by having custom-made prostheses, it allows for the multi-surgeon team to operate simultaneously. Someone on the leg or someone on the hip and someone on the face or on the neck. It gives us better accuracy and quality of reconstruction, and the whole VSP process and planning improves the surgeon and the trainees' understanding of the case requirements, and you can train people of all of the involved disciplines, which for us is oral and maxillofacial surgery, plastic surgery, and otolaryngology, head and neck surgery, in the principles of resection, because the VSP allows you to visualize the resection before you do it, and the principles of reconstruction. So what are our challenges? Our major challenge is we have to reconstruct both hard and soft tissues, because most of the work that we do is not just take out the bones and replace the bones. The work is take out the tumour, and the tumour has no respect for whether it's hard or soft tissue. So tumours can infiltrate muscles, the tumours can infiltrate soft tissues and fat, and the tumours can infiltrate bone. Then you have to remove the tumour with what's called a safety margin. The safety margin is well accepted as 5 millimeters pathologically. That means when the pathologist looks at it, he wants to be able to tell you that the tumour is at least 5 millimeters away from the edge of your resection. But in order to achieve a 5 millimeter margin, you have to excise much more, because the pathologist is working with firstly tissues that have shrunken but after they've been excised, and secondly, tissues that have shrunken through the whole formalin process. So you can have a shrinkage which could be 20 or 30%, and it's variable for soft tissues and different soft tissues. Not every bone flap can provide for all of the goals of treatment, and occasionally you need to have a second flap available for soft tissue repair, such as for skin closure. With most of our head and neck resections, there's a substantial amount of lining removed, so it's oral mucosa, muscles, and some of them have skin resection as well. Equally, if we're dealing with skin cancers that are infiltrating into the face, then you have a lot of skin excision, and you probably end up with a substantial mucosal excision. So you need to have flaps that can provide for that soft tissue reconstruction. There's a complex anatomy, and I've here got an exploded face for you of the mid-face, and there are many fine bones and cavities, including all the sinuses, and it all leads up to the skull base. So you've got to have reconstruction that respects that. We've got to consider the requirements for facial aesthetics, because people can't put their jacket on or put their jumper on and hide their operation site, or pull their trousers up and hide the operation site. They have to wear the operation site available to the public. So the shape, the contour, the color, and the texture of the reconstruction is very important. And we have to allow for that in the selection of the skin flaps. There has to be utility in the flap reconstruction to deal with post-operative radiotherapy. Probably 60 or 70% of patients have post-operative radiotherapy to try and improve their chance of survival. Surgery alone is seldom used. And dental rehabilitation is another challenge. If people have their jaws removed or parts of their jaws removed, they're going to lose multiple teeth. And if you have to go out and function without your teeth, it's a challenge. So we've got to take that into account. Seem to have jammed my slides. So what are the VSP requirements for oncology? Well, firstly, you need to have cutting guides for the jaws so that you can have a planned excision and actually do the excision that was planned, so that the reconstruction that's planned fits the defect. You need cutting guides for the donor site, such as the fibula or the iliac crest or the scapula, anatomical models which help you in the operating theatre, and the patient-specific implants. We need to have an expert, experienced planning team. We need the provision of materials within 14 days, preferably 7, because you don't want to turn to a cancer patient you see in the clinic and say, oh, well, we're going to get all the planning done. It'll take us about a month and then we'll operate on you in 6 weeks. Meanwhile, their cancer's growing. It's not appropriate. So you've got to be able to operate within the required time. The rules are that these patients are called category 1. Category 1 means must be operated on within 30 days or the hospital is penalised. And there are research and development opportunities that we can have through the VSP process. The second part of challenges, which I'd like to highlight today and is of interest to us for research purposes, is the attachment to the mandibular condyle can be challenged by tumour extent after you've allowed for adequate soft and hard tissue margin. So if you're able to preserve the mandibular condyle, leave enough bone on the ramus to attach a plate to, that's wonderful, but often you can't. And our project is we want to assess what's the minimum amount of condyle that you can attach to, because the condyle takes a lot of stress, and if you have only a flimsy plate and flimsy fixation holding the condyle onto your construct, then it's all going to fail and fall apart, particularly with radiation. And once you've excised a tumour, if you've taken away the blood supply to the condyle, which includes the lateral pterygoid muscle, temporalis muscle, and the soft tissues around the joint, then you're also not going to be resilient to radiation therapy. So the challenges with our current research project is the weight of the construct. So in the mandibular reconstruction, if you've excised the masseter, detached the coronoid process, detach the temporalis, excise the medial pterygoid muscle, then there's not a lot that is holding the construct in place. So you've got a significant impact of gravity. And if you're crossing the midline of the mandible with your resection, it's difficult for the patient to actually close the mouth. So you've got loss of supporting muscles with a composite resection, masseter, medial pterygoid, temporalis, and the negative impact of the suprahyoid muscles, which you seldom resect. So you've got to be able to, sorry, I've gone too far. You've got to be able to support all of that weight with your construct. So you do need to have solid fixation. And we always have to balance mandibular fixation with the risk of ankylosis. Ankylosis is the fusion of the bones, and I'll speak more about that shortly. So here's a typical case of condylar preservation. So the resection has crossed to the opposite canine tooth and back into the ramus. We've got a good piece of bone at the posterior edge to attach a plate to, and we've got ample bone on the contralateral side to support plate fixation. Here you can see an axial view. I'm sorry, I'm a bit fiddly with my fingers. You can see an axial view with the existing mandible and the attempt to achieve contour. This section here is the minor segment, and the minor segment of fibula needs to have an adequate blood supply. We try to have a minimum of 2.5 centimetres for this segment in length on the medial aspect. Here you see another view of the same thing, an above view with all the measurements marked out. So we're a little bit short on this minor segment, but if you take a longer minor segment, then your contour is significantly affected. If I take one step back, you can see the relationship in the contour to the maxilla, remaining maxilla. So you've got to balance the contour with the number of segments. You can see here the fibula with the blood supply. And you want to preserve the lateral malleolus and be able to preserve stability of the ankle. We have condylar cutting guides. There is the segment for what we call a vertical subsigmoid osteotomy. So that's preserving a substantial piece of muscle, a substantial piece of bone, plus preserving the lateral pterygoid, which will give blood supply to that bone, and then the cutting guide for the contralateral side. You have fibular cutting guides that are designed to create your correct angles, correct lengths for your fibular positioning. The plate is designed, 3 screws on the posterior segment and then 3 screws on the contralateral segment. And we've put 3 screws onto the major fibular segment, and we'd have 2 on the minor fibular segment. So that gives an adequate fixation for function. So the challenge becomes when you in fact have to remove the condyle. And here you can see we're positioning the horizontal segment of the fibula above the lower border, which gives a better positioning for placement of dental implants into the fibula for reconstructing the dentition. And the cut end of the fibula has to be sculpted so that it fits nicely into the glenoid fossa. Usually we would put a soft tissue spacer in here, which could be a temporalis muscle turn down or part of the musculature fascia from the fibula free flap transfer. And the purpose of that is to prevent ankylosis. We have had one case of ankylosis which required subsequent resection to enable the patient to move their jaw. He turned up at 18 months with a completely frozen jaw locked shut. So that can happen. The other problem is, I mentioned the weight of the construct and gravity. So we've lost all the musculature here. We've lost masseter medial pterygoid and lateral pterygoid. So this will tend to droop by the force of gravity. So you've got to have some method for supporting, usually with a resorbable suture, the fibula to the arch. And by having the spacer, it is helpful for reducing the risk of ankylosis. And you would sometimes put guiding elastics with some fixation on the teeth just to support the patient in the first few weeks. Here you see an example of a plate design for this type of patient. We haven't had a VSP to try and sculpture the TMJ. I will intervene with the first question now. And the first question, in case you're going to ask me, is why aren't we using a condylar prosthesis and a fossa prosthesis? And the answer is because we're having to irradiate these patients, and a large volume of metal within the radiation field does cause distortion of the radiation, focusing, concentration, and reflection. A maxillary tumor case, and I showed you the complexity of the maxilla earlier. So the orbital floor is being resected. Part of the nasal bone's being resected. The alveolus is resected. Part of the zygoma is resected. And there is a construct from the iliac crest, which is all prepared with cutting guides. which is to reconstruct the maxilla and the orbital floor. And here you can see planning for the placement of dental implants into the iliac crest, and that can be done simultaneously during the operation. So before the fibular blood supply is, before the iliac blood supply is removed, you place the implants, and then when it's transferred, the implants are in the correct place. My closing slide is nothing's new. And this is a case done more than 20 years ago with an iliac crest flap reconstruction, implants for the orbit to retain an orbital prosthesis, implants to support teeth, and fixation plates which were bent up out of the tray. So the concepts were there 20 years ago, but I think we've refined them dramatically. And this patient had their surgery finished at about 11:30 at night, starting at 8 a.m. So it made it very difficult to keep the surgeons operating for such a long time. So thank you very much to all of you, for the audience, for listening, and to Professor Lee for inviting me. So Peter, did you want to go straight on with Ricky and then discuss at the end?
Yes, thank you, David. Yeah, thanks for the really interesting presentation and really clear description of some of the cases, very complex cases. Yeah, I think we will move on to Ricky's presentation. And then I did put a note that if you got any questions, just drop in on the webinar chat. I will just pull them together and we'll have a Q&A sessions towards the end of Ricky's presentation. All right, Ricky, over to you.
Thank you, Prof. Wiesenfeld, for the invite, and Prof. Lee to have me here. I'll continue on the same theme of VSP planning, but my expertise is in facial trauma, orthognathic surgery, and TMJ surgery. So I'm going to focus on that side of the use of VSP. Everyone can see my slide properly. I'll just hopefully, then I'll carry on. So virtual surgical planning has had a very rapid evolution over the last sort of 10 years or so. And firstly, we started using 3D generated images. So you can see in the bottom left, there's a fractured face. It's broken into multiple pieces. And we moved on from plain X-rays to CT scans and then onto 3D imaging, which gave us a lot of understanding on where the pieces of bone are going to go. So probably 10 years ago, that was our 3D planning. All we had was a pre-operative image, and then we do the operation almost free-handed, and then do another CT scan and get a 3D generated image, and we'll go, that's a pretty good job. And that's how the evolution started. And then the second sort of phase came was the 3D printed splints and guides, which we started using in orthognathic surgery. So that's the middle picture that you see there, where we were using images of teeth, CT scanning the bones, and then moving in software, moving the pieces of bone around, and then 3D printing some guides to guide us to where we want to move the jaws to. And then the most recent evolution, which is the bottom left picture, is the patient specific implants. So we can actually simulate the surgery we want to carry out. And based on the movements we've done digitally, we then print a 3D printed titanium plate, which puts the bones in the exact position we want. So the evolution has been pretty rapid over the last 10 years or so. So Prof. Wiesenfeld has gone through the advantages of VSP, but if I had to put it down into sort of what are the main things, for orthognathic surgery and facial trauma, there's definitely more accuracy. So I've just got a little screenshot of PubMed. If you put accuracy of virtual surgical planning, it populates with hundreds of papers. It's a lot of evidence out there that we can get more accurate results with VSP. Now, saying that, for over 20 to 30 years, we have done orthognathic surgery. with traditional methods, and it was also proven to be pretty accurate. So I've looked at some comparison studies where previous model surgery and VSP, we probably got within a millimeter of each other. So the question has to be raised, yes, VSP is great and it's more expensive, so is the 1 extra millimeter of accuracy worth it? That is the question to ask. The next advantage is better patient outcomes. So in more complex cases such as facial trauma, the oncology that Prof. Wiesenfeld has spoken about, and TMJ surgery is definitely better outcomes, and there's evidence for that. Reduction in theatre time is a very significant advantage. So Prof. Wiesenfeld spoke about the cancer reduction in time, but for an orthognathic surgery, if we were doing double jaw surgery, upper jaw, lower jaw, traditionally we were doing that in about 3.5 hours. With VSP patient-specific guides, some surgeons are getting this under 1.5 hours. So there's definite reduction in time, which equates to savings in for the hospital, but also it means that the patients are having less time on a general anesthetic, which is obviously a better thing. And I've also found that having 3D printed models, virtual surgical plans is extremely useful for patient education. We can explain to the patients from x-rays that we do this and we're going to move here. They don't get the visual sort of understanding of what we try to do, whereas the 3D plans, it's almost become standardized that I will sit my patients down in my rooms and go through what the plan is, and they have a very good understanding before they sign up for the operation. So it is a very crucial part of my consent taking of the patient. And I think it's going to become medical legally sort of quite important to have these plans available. So those are my 4 main advantages. Now, applications for this in the area of OMS. I'm going to talk a little bit about facial trauma. Then I'll talk about orthognathic surgery. And I mentioned the word orthognathic surgery a few times. What it means is that it is corrective jaw surgery. I'm also going to talk about temporomandibular joint surgery. There is also applications in pediatric craniofacial, maxillofacial surgery, oral oncology, Prof. has already spoken, and dental implantology. So those bottom 3 I'm not going to cover today. So facial trauma, and facial trauma is a huge topic, and there's multiple patterns of fractures that you can get in the maxillofacial area. But the one I've picked where I think VSP is extremely useful is orbital fractures. So where you get a fracture of your eye socket. So if you look at the scans there, you can see on the left eye, there is a huge fracture on the floor and also on the nasal side, which is called the medial wall. If you compare it to the right-hand side, you can see where the cone is holding all the muscles and the volume together. So what happens when you get an orbital fracture, the muscles that move the eye can get entrapped in the fracture, and it stops the eye from moving well, which can give you double vision. And more crucially, if the volume of the orbit is increased because of the fracture and if it's not restored, then the eye, the globe sinks into the cavity, which gives you a smaller looking eye. So when it all settles down, the swelling settles down, you walk around with the asymmetrical face, and this is quite obvious. So over time, we have treated this well for the last 20 years or so. We have put bone grafts in there. We've just taken titanium sheets and contoured it and put titanium sheets in there. And probably the treatment of choice right now in the role model would be a anatomically designed for the general population, a titanium plate. So it is not specific for the patient. It is based on, say, 1,000 models of humans, and they have kind of planned it that this is how it should look, and we would use that to make it fit. Problem with that is, and I'll show you some, that it can be put in the wrong places. So you can see on the CT scan, the plate was put in and it was not in the right place. It was sitting in the nasal cavity. So the reconstruction of the volume is not accurate. It also can be pushed in too far, can damage the optic nerve, so the patients can go blind. It can be put that it impinges the muscle so the eye doesn't move well. So there's probably the most number of complications in facial trauma come from orbital surgery. So these are some more examples. Another example of quite a large left-sided orbital fracture. Someone's gone and done the reconstruction, and clearly you can see on the bottom left image that they have only gone halfway through the fracture. They haven't gone all the way to the back. And that's because it's difficult to get there, scary to get there because you can cause extra bleeding, and also scary that that's where the optic nerve lies and people can go blind. So if you just look at the reconstructed slides on one side, on the bottom right, it looks pretty good, but we know they haven't gone all the way to the back. So the volume is not reconstructed, and this would result in poor outcomes. This is another one. Someone has tried to put the plate in, and they have not covered the bony ledges, and it's dropped into the maxillary sinus. And again, they've had an operation, and it's a poor outcome and has to go back to surgery. So where does, and this is the deformity. You can see here that the left eye was operated on. You can see a little scar in the eyelid. And if you look at the right and the left eye is sunken in. That's where, because the volumes increase, but the reconstruction has not restored the volume. So that's a poor reconstructive deformity. And it gets quite difficult to go back in later and to fix this. So what, this is a case of mine. This patient had a orbital fracture, which was not repaired. The patient initially chose not to have surgery, and then he came back to us saying his double vision and his eyes look sunken in. So we did the surgery 3 months after his initial injury, which is delayed. Normally, I would like to do it at about 10 to 14 days. And because it was already delayed, I had time on my hand, and it was a secondary reconstruction, which means it was delayed. So I went and did this patient-specific 3D printed plate, which means that what we do is we get the scans done. The engineers would mirror image the orbit on the right-hand side onto the left-hand side, so we know where the bones need to be. Then a patient-specific plate would be designed over the defect size and with 3 titanium screws to be gone in. So the advantage of this is when we dissect the orbit, we exactly know where this plate's going to sit. There's only one place it can sort of lock in. And if you get it locked in that position, you know your construction is correct. The other thing is then you know that it's going to be in the right position. And it also gives you confidence to do this surgery quicker. So an hour-and-a-half orbital reconstructive surgery will be done in about 30 minutes. And this is the post-op scans, and you can see how nicely it fits exactly where you need to go. So this is an example of a custom plate in facial trauma. So next thing I'm going to move on to is orthognathic surgery. And just want to show where we've come from. And this was the very standard that everyone did for about 30 years. We'll do a lateral ceph X-ray. We'll do the tracings on it, and we then on the tracings will predict where the jaws need to go. So orthognathic surgery, for who don't know, is corrective jaw surgery. They have deformities of their bite and face, and we would usually put braces together and get the jaws aligned properly so their bite is fixed and their facial deformity is corrected. What we used to do is, and all of us have done this for hours, we just take molds of their teeth, measurements, how it related to their skull. We'll have this poured in the lab, we'll make all the markings, and then we'll know where the jaws, the teeth need to go. We'll cut the models up, we'll measure it and move it around, and we'll stick it together. And then based on this new relationship, we'll create an acrylic splint between the top and the lower jaw. So this kind of model surgery for upper and lower jaw surgery would take anywhere between half an hour to hour and a half, depending on the complexity. And this would all be done in the lab by the surgeon before doing the surgery. And it worked well. And there was thousands and thousands of these cases done, and they all had fairly good results. And the surgery in orthognathic surgery, you can see the model where the red line is in the upper jaw. That's where we do the Lafort 1 osteotomy to move the upper jaw. And then you can see on the bottom, there's sagittal split osteotomy in the mandible at the back and the chin movement in the front. So that's the 3 sort of workhorse places we do the cut. So bottom pictures are how we access the maxilla. We go through the mouth, there's no scars in the face. The middle picture shows the maxilla has been separated from the base of the skull and can be moved like a denture. And the third one shows when we move it into position, we put plates and screws once we are happy. So someone like that who had a very gummy smile, they did not like how much gum they showed and they couldn't get the lips together. And so someone like this has had double jaw surgery where we move the upper jaw up to hide the gum. And this was all done on model surgery. And I would say that she's had a fairly decent result. Now, this is another example of a pre-VSP days planning. So someone's had a chin asymmetry, the chin's off to one side, they didn't like it. And we'll do the measurements clinically, and then we'll go off and draw a little diagram. You can see there. So it says you need to drop it down on the left and put a bone graft in there. And we'll carry that out in the surgery that was shown. And I also got a fairly good result. So orthognathic surgery has been done for quite a few years, and we got pretty good at it. But now the standard has changed because we have got the possibility of VSP planning, and we can be more accurate. And the biggest thing is we can also get patient-specific plates printed that we know that planning is executed the proper way in surgery. So this is a case of mine. She's a 36-year-old female who presented with this facial asymmetry. This is quite a deformity. And if you look at her x-rays, you can see on the right-hand side, her jaw has grown much more than the left side. So that's what's caused the twist in the face. And this is an example of how we would carry this out now. So there's no more going to the labs to cut the models. I would get my photos, my records, and a CT scan done of the face. Then I would sit with an engineer, and this whole process probably takes me 5 minutes in the morning before I start work. And I log on and we do this discussion. So we have first step where it says intermittent position step 1. We have done a segmental osteotomy of the upper jaw. So we split that into 2 pieces and expanded it. And then we have done a sagittal split osteotomy in the mandible and a chin as well. So what happens from that is once you move the upper jaw, there is the red guides you can see between the teeth is 3D printed, and those are shipped over to me. And then when I go to surgery and I actually move the jaws around, those 3D printed splints are used to guide me to where the bones need to go. So it's basically translating the information from the virtual surgical surgery into my operating theater. And it also tells me what other movements I have to do. For example, the chin, it's fairly accurate. It tells me I need to take 4 millimeters off there, bone extract, etc. And we do the surgery in the operating room. You can see there's titanium plates and screws. These are not patient specific. You don't have to always use patient specific, and you can get a result like that. So she's fairly happy 3 months down the line. And if you need to compare pre and post, so that's a happy patient. And the educational value of the VSP really helps to guide the patient to see where they're going. So that takes me to TMJ Reconstruction. So this is a case of mine that I did at Royal Melbourne. She was a 21-year-old female who had a history of rheumatoid arthritis, and she was under the care of rheumatology at the Royal Melbourne. So if you look at a CT scan on the bottom right of the screen, you can see the left joint is pretty arthritic, and she was having a lot of pain, unable to move. It's almost getting ankylosed. What Prof was talking about is fuses to the base of the skull. What we did for her, you can see here again, this is all patient-specific 3D printed. So I would sit with the designer and plan where I'm going to do the resection of the ankylosis. Once we have done the resection on the 3D digital skull, then they would design a joint that will specifically fit for her. So even the fossa component, which is on the zygomatic arch, and you can see that on the photo, the high density plastic, you can see with screws in it. And also that silver thing you see is a titanium part of the joint coming up. So it all is patient specific. So it means that when you put it in, it just clicks onto the remaining bone, and the results for that are much more superior. And that's what it looks like on the x-rays. So then what we can now start to do is combine orthognathic surgery and TM joint replacements together. So this is another case of mine. He's a 25-year-old man who walked into me with this deformity, and this was his bite. So all he wanted was to have his bite fixed and his deformity corrected. And when we did his scans, we saw this quite a large benign tumor, size of a golf ball, in his right condyle. And we could have fixed it previously, but with the technology, it becomes much more easier. So you can see we have planned it VSP. We've got a move the mandible, move the maxilla, and we also planned patient-specific plates. You can see in the bottom left, after moving the maxilla, these plates are patient-specifically printed, so we know where the movements are going to go. And what it does is it gives you a result like that. And this is 3 months after surgery, and his bite's fixed, his deformity. This is almost life-changing for this guy. So in conclusion, I would say that definitely VSP has improved my planning. It's given me more accuracy in reconstruction, has reduced the operating time. The main downside right now, which is more of a downside for the oncology surgeon than for me, is the turnaround time for getting this done. Because in deformity, you can wait 2 or 3 weeks before you do operate. And the main problem is the cost. So for orthognathic surgery, for me to use VSP planning, 3D printed splints, etc., for every case, we are spending about $8,000 extra. Now, I am not sure the 1 or 2 millimeters of extra accuracy is worth $10,000, which is what we need to focus on. Thank you very much, and I'm happy to take any questions through my email if required, or over here.
Oh, once again, thanks, David. Thanks, Ricky, for the very exciting presentation. There's been a flourish of questions coming in, and I see, David, you've been answering them. I'm just wondering, yeah, I think in the system allows everyone to look at your answers. So I hope that's the case. But maybe what I can do very quickly is repeat some of the questions that have been asked while the presentation Ricky had was going on, and then there are a couple of new questions coming in for Ricky as well. So there was a question about the iliac crest flap. How complex were the guide used for fashioning the ilium? This is with regards to David's presentation. So you indicated that they have to be very simple, and I think pay attention to the access issues. And then there's another question around VSP regarding extra engineering. It's expensive. Are you able to comment? So David, you mentioned you've never seen the bills. Yeah, but I think that is a interesting one, because I think Ricky, you sum up in your presentation the concern about cost, and even whether these costs are worth it to achieve some of those accuracies that you mentioned. Perhaps maybe we could expand on that a little bit. What do you think, Ricky? With regards to whether how expensive are these engineering challenge, and yeah.
So the cost I quoted of $8,000 for orthognathic surgery is what the industry companies are charging the hospitals or the insurance wherever you do it. The way forward that I see, and Prof may agree or disagree, in a few years' time, the software for digital planning and a 3D in-house printer is the way to go. That will significantly reduce the cost. Right now, look, to print a 3D wafer that we use in orthognathic surgery is probably worth $40, but we are paying $8,000. And that is the cost of the research and development that's gone into it. But bringing it all in-house is the way to go.
Yeah, there's quite a bit of discussion about point of care, and whether in-house manufacturing is viable. Yeah, good point, Ricky. So there's another question, to David. Whether you have to make any adjustment intra-op to the pieces compared to the virtual plan to ensure that they fit. So you indicate that very rarely the planning indicating resection plan is correctly performed. Yeah. So I suppose, David, you want to comment on that? Do you find the accuracy in the VSP always to your expectation?
The accuracy depends on good planning. And the first thing is the surgeon that's going to operate needs to define what they're going to take out. One issue that arises is the surgeon took a little bit more to make sure they didn't have to do an adjustment. So if you think that you need to allow a certain margin for bone infiltration by the tumour if you take a little bit more of a margin, you're less likely to have a surprise when you operate. Because once you cut the specimen, if you fall into the tumor while you're cutting the specimen, that's a disaster, because then the whole VSP is inappropriate. And then you end up lengthening the amount of fibula that you need to provide, and having to do that freehand, then all your advantages have disappeared and the accuracy is deteriorated dramatically. So probably there's a tendency for the surgeon to take another 5 millimeters or another centimeter more than they would otherwise have as the minimum amount to get over that problem. Because your assessment of tumor infiltration into bone marrow radiologically is difficult. Certainly with a CT, it's nearly impossible. And the MRI can be difficult. So you would err to maybe, instead of a 15 millimeter surgical margin, which would be your plan, normal plan, that you might extend some cases to 2 centimeters. But then the implication of that is very small, because once you're actually operating and taking out a large segment of bone, whether it's a centimeter longer or a centimeter shorter, for the reconstruction doesn't matter. But if you have to change in the middle of the operation, that's a disaster. So that problem seldom occurs. And the problems that we've had, I've already mentioned 2, which is ankylosis, but gravity is another serious problem for us for accuracy, because if the weight of the construct is more than the patient can bear, then they tend to have sag on the operated side, and the mandible then sags down. They have a poor occlusion, they have poor symmetry and poor function. So somehow you've got to balance that with the way you do the fixation. So I think, yes, it is a real problem. And our problems have mainly been with sag, where a lot of the muscle has been taken and the patient just doesn't have the ability to close their mouth, and the mandible drops.
Right. Thanks, David. Ricky,
That's hard.
Yeah. Ricky, what do you think? Like, do you, in the aspects about what you do in the VSP? Do you I mean, David highlighted that you if you do it properly, you don't get difficulties. But what if you make a mistake in the VSP? Then will you have a device that you just can't fit then?
True. So you have to be very careful when you do virtual surgical planning, VSP, and also when you're doing patient-specific implants. If there's been an error in that the device will not fit, or it will fit but lead to inaccurate positions, and that could be a problem. So in VSP, there's 2 points to check. One point is when I'm actually doing the planning, and then a whole report comes back to me to sign off, and that's my second point of check that before I sign it off. Now, I've been using VSP for about 8 years now, and I'm getting more confident in that system. But when I first started, I was getting VSP plans done, getting a 3D printed splint made, and I was getting my registrars to still do the traditional model surgery. So I went to theater with 2 splints, and I usually checked the VSP and the model surgery splint actually gave me the same results or not. I have moved away from that as my confidence in the VSP has grown and my experience has grown in it. But yet I definitely started off with both systems in theater at the same time. And I think we, obviously David is much more experienced, but I went through a period where I did the model surgery and then I moved on to VSP. So I've got the advantage of falling back to my old ways of doing and being able to complete the surgery. But I do worry about our new trainees who only very heavily rely on VSP, have never done a model surgery ever. So yeah, there's a skill being lost in maxillofacial surgeons.
There was a question about, a lead time for engineering, whether it's an issue. I suppose, you are also dependent on the engineers quite a bit. And of course, similarly, as in engineers, there's always good engineers, there's always bad engineers. So in your own experience, do you find engineering can be a hurdle, or and are there issues that can be improved or overcome? Yeah.
I'll just answer my part of that before I let Prof. Engineers are very much part of this team, and as Prof said, this is a teamwork. You have to have confidence in the engineers. There's been once I abandoned the planning process and I had to ring back the company and say, please give me another engineer, because I lost total confidence in the planning process. So I had to abandon it. They're very important.
David?
Yes, I support Rick. It is teamwork, and you've got to have an engineer that you trust, and the engineer equally has to trust the surgeon, because there are cowboy surgeons that will come to an engineer and want them to do something that's totally impractical. So that's a balance, and being confronted with the conflict situation in the team, well, you've got to resolve it somehow. And in the end, the surgeon is the one that picks up the knife and has to take responsibility, is the one that suffers if things aren't right. So if you've got to move on and change companies, change engineers, well, you have to do that.
Yes.
But it's a professional relationship and appropriate courtesy and respect.
Yeah. Thanks. Well, I'll go to the new questions. I noticed, well, I don't know how you do it, Ricky, while you're talking and you're typing the answers. Right. So there's another question. It says, thanks for the presentation. I'm interested to know if you have any experience using personalized cages scaffolds for bone regeneration in critical size defects that are sort of greater than 6 cm. And what role you think tissue engineering will play in maxillofacial reconstruction in the near future? Anyone, please go ahead. Yeah.
So I have given a lecture on this subject of tissue engineering and the use of scaffolds. It wasn't based on experience, it was based on literature, but I don't see patients who need that. So they don't come to me. We have done some cases of transport using devices for tissue expansion, moving bone over a 3 or 4 month period, but they're very select cases. And in the oncology setting, you wouldn't use any of that because of the issues of radiation, and you've got other issues on your mind other than trying to be experimental with tissue engineering in a cancer case. If it goes wrong, it makes a terrible mess.
Okay.
You got something to add to that for
Ricky?
critical defects?
No, probably the critical defect things come into your area more than mine, Prof.
Yeah, but do you feel, in this space, the tissue engineering has a role to play in the near future? I think maybe even we could expand this discussion about soft tissue reconstruction has always been a challenge, right? Or even attaching soft tissues to implant, for example. Yeah. Any comment on this? Yeah. Good to get some ideas so we could create PhD projects from you.
Look, I think tissue engineering is going to be a critical part of medicine and surgery in the future. So I don't think this sort of technology is going to replace tissue engineering. I think they go hand in hand.
Yeah. There's another question for you, Ricky. I think you guys been discussing the click conceptually. Yeah.
So we're talking about sort of joints, they sit on the bone quite well, and it doesn't click onto the bone. So what we actually do, for example, with joints, we have guides which we put on the bone and sort of wraps around it, and we have holes that we can drill, and then we take the guide away, and then the implant comes in and sits over those holes, and the screws go into the pre-drill holes. So that's how we get it to sit exactly where we have planned it. So it kind of clicks, but it's not like it just clicks in one place and doesn't move. There's still some.
Right. Good. Thanks. There's another question for Ricky. Can you comment on the differences in the use of VSP in OMS, right, between pediatric and adult cases?
Oh, yes. So we've started using a little bit of VSP. So I'm involved with little babies who are born with very small jaws and can't breathe, and we bring their jaws forward by distracting the bone. And one of the things, we have to cut through bones, which are in what we call babies. They're very tiny and they have tooth roots and nerves in the middle. So we have sort of done a few cases at RCH recently where we made cutting guides which help us avoid the future tooth roots and the nerve that gives sensation to the lip. And so that's an example of applying virtual surgical planning to babies like 4 weeks old.
Oh, wow. That'll be, the guys must be tiny.
They're tiny, and they're expensive. So I'm not sure again whether we should be paying for that. I keep bringing it's expensive. I don't know why.
All right. Yes. Oh, well, we are at 1:59. So I promised to finish it off at 2 p.m. And so once again, I think, if we are all clapping, you should be hearing from us right this moment. Yes, and thanks, David, and thanks, Ricky, for this, really, really excellent talks. And I think I can see quite many engineers in the audience. I think they'll appreciate your time and, in educating us. Thanks very much. So, right, thank you.
Thanks for the opportunity.
Right, thanks.
All right, see you.